So I take my responsibility as a watchman, as someone who watches over Indigenous populations, and traditionally a watchman, and it's not gender specific, but a watchman figure in Haida tradition was a figure who would like literally start speaking, a figure at the top of a totem pole that would literally start speaking if danger was approaching. And in our tradition, it's someone who watches over the people. They have an expertise about who's at risk and who isn't, and they can start to speak about that person, saying we really need to watch that person and how it's going. And I'm reminded of a patient that I saw, a residential school survivor, an elderly man with rheumatoid arthritis, who was having a flare, and really all he needed was a pulse of steroids. And I was trying to explain to him how the pulse would work over the next several days and how the pill count would change. And I said, I don't know, I should write this down for you. And he said, do you think I'm stupid? And I said, no, my gosh, no, that's not what I meant at all. I want to be really clear with you. And our ensuing conversation was about repairing the relationship between a patient and a physician. He clearly didn't trust doctors, and I had to bring my knowledge and love of First Nations people to him and say, I know about residential schools. My parents are residential school survivors. They met in residential school and fell in love. They were going to testify at the Truth and Reconciliation Commission. They never quite, another story. I understand where you're from. And so fixing that relationship was important, and I really realized that I needed to bring more than my script pad and my training with me to my encounters with Indigenous patients. So our job as watchman in our office, as the Office of the Chief Medical Officer at the First Nations Health Authority, we do have some physicians on our staff, and they're right here. I'd like for them to stand if they could. Dr. Shannon McDonald, my deputy, Dr. Kelsey Louie, the Medical Officer for Primary Care, Dr. Sean Wachtel, the Medical Officer for Health Services, and Dr. Anjali Malhotra for Women's Health. And I hope that you will get to know them. Their work with us is seminal. Let's go to the next slide. So I quote, "Racism and discrimination towards First Nations people continues to be a major problem in many contemporary healthcare settings, resulting in a lack of appropriate treatment and barriers to accessing healthcare." And that's Dr. Billy Allen and Dr. Janet Smiley for the Wellesley Institute in their seminal work, First People's Second-Class Treatment in 2015. We know that infant mortality for First Nations people is 1.5 times higher for us than for other Canadians. We know that the average life expectancy for Aboriginal women and men is 5 and 9 years less, respectively, than for other Canadians. In our own lands, we have this severe disadvantage, and that your care, your culturally safe care, can have a positive impact on our outcomes. And I know that none of us like to think that we have a bias against certain of our patients, but we certainly must be self-critical. When I receive complaints about physician behavior with Indigenous clients, the initial response is always, I treat everyone the same, I'm fair, I don't think there's a problem. And I have to respond, then what happened? Why is this patient reporting to me that something bad occurred with you or with one of your staff? And then we try and figure it out. We know from training, trying to add training to 100,000 healthcare workers in the province of BC, and they take this course, it's called the Sanyas Cultural Safety and Humility Training Course, that there are hotspots where there are BC healthcare workers who have particularly odd stereotypes about First Nations people. That healthcare workers who are in emergency rooms, maternal care, pediatrics, acute care, ICU, surgery, mental health addictions, and in home and community care have a significant, statistically, a significant bias compared to other workers against Aboriginal clients. And what Sanyas has found in their training, and it's an interactive online training program, when people are making comments, that about 10% of the healthcare workers that we're training are called disruptive they have a lot of trouble kind of fixing their views. And I try and think of, this sounds so like man bashing. Those 10% of men who can never get that women are equal or that women deserve to have a good workplace or not be subjected to abuse, and that they deserve equity. I liken it to that. And I don't want to focus on those 10% of healthcare workers who don't get why Indigenous people deserve equity. I want to focus on the 90%, who understand that equity is a goal within a clinical setting. And these hotspots are consistent with the literature and other research studies that examine Indigenous people's harmful experiences within the healthcare system. Here's a slide around general practitioner attachment. This is the trend in attachment rates by age group for First Nations people from 2008 to 2015. And you'll see the very, very, very bottom, I think it looks orange to you. Is that right? Does it look orange to you? The lowest line is for our younger populations, and you can see an attachment rate that's declining over time and is now around 70%. The top two lines are our oldest members, who are between 65 and over the age of 75 years old. And you can see their attachment to GPs is much higher, but still a declining trend over time. We need to do something about this. Here's another slide around GP attachment and emergency department utilization by gender. And First Nations attached are the solid green line. It's kind of third from the bottom. And First Nations unattached are the very top line. So really, it just means that unattached women, or GP unattached First Nations women, tend to use the emergency department at very high rates. And this signifies to us an inappropriate level of care, and of course, considerable expense, considerable spend of resources. Here's a GP attachment, GP attachment and emergency department utilization by health authority. All regions have higher emergency department user rates amongst the unattached, between 47 and 54%. But the difference between the unattached and between the attached and the unattached emergency department user rates was highest in Fraser Salish. The inequity was the highest in Fraser Salish and lowest in the north. This is information from the Sanyas course again. We recognize that cultural safety and humility exist along a continuum. At one end, we have cultural awareness and sensitivity, which are about focusing on culture and cultural difference. And this includes focusing on diversity and multiculturalism, which can be a starting place for some organizations. Focusing on this end of the continuum presents risks for reinforcing stereotypes and framing Indigenous people as other. It's a bit reductionist, and for us, we would like to have a more sophisticated approach to cultural safety and humility. In the middle, we have cultural competency and cultural humility, which are about practitioners changing themselves. It's my timer saying it's time for questions. And cultural safety, at the very end of the spectrum, is our goal, and that's when Indigenous people feel safe within the system and are not discriminated against or stereotyped. This is a picture of me and my friend, Dr. Emmett Aluli, who's a Native Hawaiian physician. I often go to Hawaii. Sometimes I work in Hawaii. When you're in Hawaii, you know you're in Hawaii. Hawaii is a beautiful paradise, and it has a very interesting parallel colonial history where all of the islands used to belong to the kings and queens of Hawaii, and then it passed into private ownership. And we see the Hawaii now that everyone absolutely loves. And it has teachings for us, I think, as Canadians. We also live in an unbelievably beautiful paradise that affords us an unbelievable level of existence that is the envy of many people in the world. And when you're a healthcare worker in Hawaii and you're working with Native Hawaiians, you try and be culturally sensitive and not be a terrible person. You try not to bring inequity, segregation, and hostility to the paradise. So are you contributing to the paradise, or are you making it rather hellish? So here are the scientists' recommendations: to speak up and talk about racism, to name stereotyping, to gather data and stories about Indigenous people, to examine why and where harms occur, to reflect on practice, and to reflect on your workplace culture. Providing culturally safe care can have a positive impact on health outcomes. A culturally safe and culturally humble clinical encounter is one that is based on mutual respect, understanding, and reciprocal accountability, one that provides an understanding of what health and wellness means to the First Nations person, not just to the clinician, and one that resets the balance of power between a care provider and the client that we are here to serve. I just wanted to remind you that the Royal College of Physicians and Surgeons made a landmark decision to make Indigenous health a mandatory component of postgrad medical education, and that they will focus on improved health and healthcare outcomes for Indigenous peoples. And that means that the Royal College's fundamental business of accreditation, credentialing, examinations, and the maintenance of certification will change as well. The Indigenous Physicians Association of Canada will be hosting PrideOc 2020, a gathering of Indigenous physicians, and they have stated in the past decade the Association of Faculties of Medicine of Canada and individual medical schools have made significant progress in the areas of curricula devoted to Indigenous health and training of Indigenous physicians. And I think that's where we want to go. And our esteemed leader, Dr. Heidi Otter, the Registrar and CEO of the College of Physicians and Surgeons of BC, was a signatory on the Declaration of Cultural Safety and Humility for Indigenous Peoples. And I quote her: "Physicians need to understand and respect the unique history of Indigenous peoples in order to provide culturally appropriate and safe medical care. Signing the Declaration confirms our commitment, our collective commitment as physicians in BC, our commitment to continue to promote the value of this important training to physicians." Imot, thank you very much.